go live on.
Connect streaming software to go live. So that's.
Can you mute yourself?
How do I get back to? Uh-oh. Hello, everyone. So we were just connecting to Facebook, a couple last minute glitches with our groups there, but I was just letting more people get in. So we're going to have a great discussion today, and then I'm going to talk for about 20 minutes, let a few more people get in, and then we're going to I'll talk maybe 20 minutes or so just on some obvious gender differences in medicine and how it relates to my practice and regenerative medicine and hormones and sexual wellness. And then I will open it up to some questions as well. And that'll further direct the conversation. So, this is our first live event talking about the gender gap. And if you don't know me, I am Dr. Durst, and I am the owner and founder of Revitalize MD in Knoxville, Tennessee. And I specialize now in regenerative medicine with a focus in sexual medicine. And so the practice is there to provide solutions for patients that are looking for something non-traditional that doesn't involve medicines and surgeries. And my story is that I was greater than 20 years in the ER and actually noticing a lot of the changes as we age that a lot of our patients are coming in with. And so basically, as I started to realize that there were options and solutions, I wanted to put them into practice and to allow patients a practice that was going to comprehensively address their concerns, because over and over again on a daily basis, we hear how they pretty much get ignored by their primary care doctors and sometimes their OBGYN or urologist. So there is a huge gap in medicine that has become more obvious because we hear it every day, and the practice has grown just in patients looking for those solutions. So basically, I almost consider Revitalize MD a gap in medicine. I see one medical professional on the live stream talking about leaving traditional medicine or healthcare, and that's probably because it is broken. And so we have to improve our medical community and systems. So some facts related to gender bias. There are study biases. So historically, and this is a well documented fact, that many studies do not include women. So women aren't represented in those studies. So a lot of times we have actually been studying medications and treatments that are studied on men and then applied to women. And yet, a lot of the reasons why women are not included in those studies, is really because of the variability of women in the physiology and the variations of hormones. But that's exactly why we need to have more data specific to women so that we can actually see how it impacts women. And instead of just applying something that is studied in men to women, but yet using the exclusion as the fact that we're variable and also very different than men. And so that was one of the reasons why we've been excluded. And then again, we just have lack of data then that support the treatments that we're doing for women. And so we'll get into that a little bit more, the history of that. But then there's also a lack of focus of female-related conditions, and there are lots of them. And so therefore, there's just a delay in care, misdiagnosis, and not a lot of knowledge from the medical community related to some significantly impacting menopause patients and even perimenopause leading up to that. So there's been inadequate options for HRT for women, and those do exist for men. And so there's been a significant impact to women in their access to care. And so we'll just talk about at the end how that's the biggest chunk of what we're going to talk about today, is the impact that we have seen in patients on a regular basis in the office, and something that we hear on a daily basis. So, and how we move forward from that. And then we'll open it up to questions. So if we look at studies, starting back in the 1960s when thalidomide was studied, again, there were lots of birth defects after. And so then it became in 1977 that they actually would not accept women of childbearing age into studies because of the risk of birth defects in those studies. And that's, a valid concern for sure, especially after that birth defect that was noted significantly in 1960 with thalidomide. So, but we also have just a variability in how we metabolize stuff. And so there's a lack of data that applies across, both genders. And there's clearly a difference. Ambien would be one of those. We basically were prescribing the same dose for men and women, and yet it was a half a dose for Ambien that was needed at the time for women, but it took us years to figure that out. We are more likely to have adverse reactions to medicines. We have hormones that are in play, they're changing all the time. And so that's huge. Cancer research is another one. While we may have a lot of research related to breast cancer, other female related cancers such as uterus and ovarian, they are studied less. And even if there's cancer such as lung that is prevalent and very common across both genders, there is lack of women that are represented in the studies related to those cancers. And then again, when we're talking about a lack of female focused conditions, a lot of the autoimmune conditions are more common in women than in men, and yet the studies are mainly of men. And so basically that's a huge one. But we also, with this, lack of access to care, we have low T clinics everywhere. And this is kind of where the focus of this talk is going to be, how we stopped hormones in women, how the medical community still don't know about hormones in women and the safety. And there's lots of safety data out there, but we're still scaring women away from that. But we have low T clinics for men, and testosterone is the most common and abundant circulating hormone in a woman's body. So that need is there. And again, women, because of variations in hormones, they also, and progesterone and estrogen, that decrease, and even testosterone with age, that we are more likely to have mental health concerns such as depression, anxiety as we get older. And as we know, the first thing that a lot of OBGYN doctors will do, or primary care doctors, is somebody's not sleeping, or if they're depressed, or if they're anxious, then they go ahead and put them on medications for that. So they will put them on anti-anxiety and antidepressants and sleep pills, but that is not what they're deficient in. They're deficient in hormones. And so, as we know, the WHI study was started in 1993, and it was terminated early in 2002 when they had reported a risk or an increased risk and incidence of breast cancer, cardiovascular disease, clotting disorders, with a decrease in some things. But again, that was a completely misrepresented data set. And so there's a lot of problems with the WHI that doesn't apply across the board to what we're doing now. One, it was all synthetic. So all that data was synthetic. There were two arms, one with estrogen and a progestin. And the progestin was only used if a woman had a uterus. And that was because they thought it would be uterine protective, but there are receptors for progesterone outside of the uterus. And that's why it helps with sleep and mood. And that's why as we hit perimenopause, we start to get a decline in progesterone. And so therefore you will end up seeing sleep issues, depression, anxiety, but we're not in need of medications that have side effects. What we're in need of is hormones that we can optimize to help with those conditions. And so we will across the board see women on a daily basis. And that's what the focus of this talk is how we see women that are desperately seeking physicians to listen and solutions, and they just aren't finding those in traditional medicine. They're not finding them with their primary care doctors. They're not getting the solutions or even discussions that are opened with the GYN doctors. And frequently, again, they're told, it's normal, it's part of aging. They'll write them a prescription for sleep medicine or anti-anxiety, antidepressants, and they are proactive. They're looking for solutions, and they just don't have a lot of places to find those solutions. And that is the impact that we're noticing with women. And that is what this talk is about. And we have this conversation with women on a daily basis. So, for instance, somebody goes in, and even as our sex drive decreases with age, orgasmic strength, sensitivity, vaginal dryness, all of those are things that we can optimize hormones and get improvement of symptoms. And so basically, when we talk about low sex drive and we talk about testosterone, it is known that a man can go into the primary care doctor, and at least now we've progressed enough to look at hormones. They don't always open the conversations or provide solutions that they should. So you'll still hear a lot about men, and it's in the normal range. So it's just normal, but is that normal for that man? Because that man may be experiencing symptoms of low testosterone, but it is within a normal range of 300 to 900. And that's a wide range, and that's based on a variation of age, not just one age range. But when we do testosterone for women, and that is a gender gap and a huge one, because when I opened Revitalize, probably the two biggest gaps in medicine that I saw. And again, I went into it because I wanted also out of medicine, because everybody wanted a prescription of some sort or medication. I was in the ER. And so it could have just been an antibiotic for a bronchitis or for, a viral infection or a sleep pill, but it was still a prescription for something. And I just wasn't really of that mentality. But I saw a lot of women just with low sex drive, anxiety. And if I could have given them progesterone and an IM shot, I would have been doing that in the ER, but that didn't exist at the time. I go to my first anti-aging conference. I realized that there are hormones that you can use and optimize, and even other things such as peptides. And I do see a peptide question up, which we will definitely get to, because that's another gap in medicine, period. And I think that what we're doing at Revitalize is really filling those gaps, whether it's a gender gap or whether it's just a gap because we want to give medicines and we want to, we provide what we're taught, right? We're taught to put people on medicine, and then we're not really taught to take patients off. So we start it, but we really never take them off of that. And what happens is we wait for a disease to happen, and then we are prescribing a medication to treat a disease. And what I love is that we can actually prevent diseases. So we can optimize the body with peptides, and we'll address that, or hormones, and you're optimizing the body so that it doesn't necessarily need a medication or surgery. And instead, you are giving the body back what it needs to optimize, to heal, to regenerate. So basically what we're seeing, that was the first gap in medicine, is just that there were solutions that weren't offered. I knew we can offer them. Sexual wellness was one piece of that, because we have erection changes. We have, vaginal dryness, orgasmic changes that happen with age, and childbirth, and, decreasing in hormones. And we just didn't have a way of improving that. And so sexual medicine was a huge gap. But the women and hormones and women and HRT was the next. And women and testosterone is big. Testosterone, the most abundant hormone in a woman's body. And if you look at the concentration and the actual concentration units, you will see that when you report it. So it's the most abundant, and there is still no approved testosterone preparation for women in the US. Testosterone has been safely studied. It has been used for 60 years, and it has been used and approved in the UK and Australia for women and testosterone in women. But there is still no approved product in the US for women, but we have 30 approved products for men. So that's a huge gap. And yet we have major guidelines and consensus statements being put out by societies that will say the only treatment for women would be a hypoactive sexual desire disorder, and that's it. So low libido, and that's it. Yet there are receptors for testosterone in all of the female sexual organs. And a decrease in orgasmic strength is also noticed, decreased responsiveness, arousal, vaginal dryness, lubrication. And so it's not just drive, and yet they will cite a reference for just a low sex drive and topical only, and yet their reference will say how it can be used in other forms, and it does more for women than just address a low sex drive. So I think that the big issue for me is both men and women, as they start to notice changes, should have the options and solutions available. The problem is we don't have that for women, and they are frequently scared. And even if we have them optimized on testosterone and they feel amazing, then they are actually scared when they go to their primary care doctors or OBGYN doctors, and they want them off of that. So that's one of them. I see a lot of questions here. So peptides best for athletes, because I think we should just address some questions as they come up. And a lot of times what will happen, there'll be a lot of women in and just discussions that naturally happen based on an experience they've had with the doctor. You know, how they're surprised they're still having sex and they're, 50 or 60. And yet that is not something that you would, that's not that same conversation you're going to have with a man, but they still have limited solutions in what they can give them. And you see the little blue pill is often given, but there's other things we can do to regenerate when we have decreased function over time. So women just aren't given that same group of solutions. They don't even use the little blue pill in women because it's not known to be used in women, yet it can be. So just addressing those comprehensively is what we like to do at Revitalize. And so we want to make sure that we do more lives like this so we can connect with patients that want to find out more, have questions. So we'll get to the question now. So what's the best peptide for athletes? So when you're talking about, depends on the age. We do a lot of peptide videos, and we have done a lot of YouTube videos on that. But you're talking, the first thing you want to do as you're getting older and you're noticing changes, because one of the reasons why you're asking is sometimes, I should say, it depends on the age. So if you're younger and you're asking, you may just have an injury and you're looking for a repair. But if you're older, you're just getting injured more frequently and you don't repair as well. And your recovery time when you're working out is not as good as when you're younger. And so if you think about the fact that hormones are also repair, and so your core would be treatment with hormones. So if you are a man and androgen loss might be something you're feeling, and that can be, again, sleep, that can be mood, it's a zest for life. It can be that you don't repair as well as you used to. It's not just all about sex drive and erectile function, but it can be those other things like you are working out, you're not recovering as well, but the core would be to optimize hormones. And then if you're looking at the next peptide, you want to optimize growth hormone in addition to testosterone. And so CJC would be top on the list if that's the category you're talking about. If you're getting older and just not noticing a difference or just not noticing that recovery like you used to, CJC will optimize your growth hormone. So now you core would be optimizing your testosterone if it needed to be. And you're looking at all the other hormones in conjunction with that, but then you would optimize growth hormone with a peptide like CJC. But if you have injury, or chronic pain, something related to a previous injury, then you would want to optimize or use BPC. And BPC is a repair peptide, and you can also use that in combination with a TB500 or a TB4, and those will help with inflammation and repair. And so I see, so my range on the lower 330 tested, but I feel like having sex isn't a problem for me. Well, that's another very interesting. And so if we're ultimately focused on the gender gap, this is a huge part of it. So with men, again, there is a wide range. So say that range is 260 to like 915, 920. That's a huge range. And that range is a wide range for age with men. So if you were 900 and now you're, 300, or 200, then it may be that you are still, I shouldn't say 200. So if you were 900, now you're 330, you still would be considered in the normal range, but it may not be normal for you. You could have been 900, now you're 300, and that's a third of where you were. And more importantly, if you are noticing some changes otherwise, so energy would be one of them, some brain fog, body composition changes, gaining weight, doing the same things that you were doing, but you'll also start to notice with men sometimes that metabolic syndrome where your waist circumference will increase, your blood pressure will increase. You have behind the scenes benefits of testosterone optimization, which would include improvement in lipid panels and insulin sensitivity. But the important thing with the gender difference with that test of 330 and you still having a sex drive is the fact that it's the last thing to go for men. So with women, it could be the first thing to go. So women might have a testosterone that isn't rock bottom, but it is like the first thing that goes with women is sex drive, where a man can have an almost non-existent testosterone and yet will still have a sex drive. So it's the last thing to go for men and it's the first thing to go for women. So it's also a little bit harder to get back for women. But when your sex drive is low, there's only a couple things that are going to cause it for a woman, and that's medications and side effects. And there are lots of them that can have that effect. And antidepressants would be one of them, anti-anxieties, even an Adderall or stimulant would. And a lot of times they might be taking that for brain fog. And so, but that's not too surprising if you have a 330 and you still have a sex drive. But what I would like to point out is that sometimes you will start to notice some erection changes. It wasn't like it was, 10 years ago, 20, 30 years ago. And so basically with that, there's some blood flow issues in addition to hormones, and about 20% of erection issues that happen with time and with age, 20% is hormones and 80% of it is a blood flow issue. And so eventually there'll be some changes that you notice. And the quicker that you notice that is when you want to get on optimizing those hormones. And CJC and optimizing growth hormone is another one of those. But again, so some of the things, 330 would not be normal and would need to be optimized if you're having any kind of brain fog, weight gain, energy issues. And if you're noticing any erection changes or any drive issues, then you would want to optimize that too at 800 to 1100 typically is the goal of treatment. So when we're talking about supplements, again, I have everyone on a multivitamin. So everyone in R is like usually on Phyto Multi, which is a metagenic favorite of mine. Otherwise, I use a lot of designs for health, medical grade supplements, because supplements are important. And so I like Metagenic's Phyto Multi as a multivitamin just because it has a lot of plant-based antioxidants, so it's energizing in and of itself. So supplements are important. That's one of them. We look at DHEA levels. And so that's another one that we're going to optimize. Typically, we're looking at maybe 250 to 350 or the upper end of a range for a woman, and 500 to 600 for a man. So that would be another one. And again, it comes in multiple strengths, but typically we're starting on a lower level, like a 5 milligram for women. But we do this based on levels, and we do follow levels. And then we do it more or less at the 25 milligram starting point for a man. And then vitamin D3. Those are the three that we're always looking at first. D3, you want to be 80 to 100, and that's important for lots of things: anti-aging, anti-cancer, energy, weight sometimes, but also huge for immune function. And again, with COVID, and when COVID hit, if they had actually looked at pushing vitamin D, that would have been the first step, because that's something somebody could have done. They could have went to the vitamin shop and got it. And everyone that was really sick in the ICU, they had some studies that showed that not one of those patients had a vitamin D level of greater than 30. And vitamin D is important for recovery too. So if you're having surgery, then you would want to optimize the vitamin D so that in the vitamin D level at the time of surgery is crucial for recovery from surgery. So those are the three. And then again, if you have lipid panels that are abnormal, fish oil is key. That's the first step. But red yeast rice, just so you know, is a statin. It's just like a statin. And so there's lots of science out there to support that. Sometimes you can still have those muscle effects or a drop of your coenzyme Q10 with the statins. And so you can maybe potentially get that too. But red yeast rice is a supplement in vitamin E that would help with lipids. And there's all kinds of things that can also help in a supplemental form just for insulin sensitivity and improving that. So the signs that HRT are working for women. Well, so women come in and the big issues that they're complaining about, brain fog's one of them. And if we look at it, even cognition and memory, and there is lots of data to support that improvement in women. And that is when we're optimizing testosterone, estrogen, and progesterone. So the two first hormones to drop, usually in perimenopause, which is 40 to say 55, is progesterone and testosterone. Those are the first two. So mood and sleep are the issues that you're going to see with the progesterone drop. So if women aren't sleeping and we optimize their progesterone, then they should sleep better. And if they're starting to get worked up over things they never did before, so they were anxious, they're, worked up over, again, button pushing, they get a short fuse. Is it because their kids are now older and they should actually be acting better than they are? Or is it that they're low in progesterone? So you should see improvement of both of those. And testosterone, that can be brain fog. So if you're optimizing a testosterone in a woman, then you'll see improvement in brain fog and energy and libido, and they'll have energy to work out. They'll build muscles better. And so that body composition change and weight gain is an improvement that they will see. And so you'll know that it's working because they feel better and it is life-changing. And the difference between hormone optimization and medications is that you actually see an improvement. And so when you have high blood pressure and we put you on a blood pressure medicine, we're treating the condition, but you're not necessarily going to get this improvement in any kind of symptoms because you're not having it. It's an asymptomatic increase in your blood pressure. But patients are coming to us and women are coming to us because they have symptoms. And so they actually have life-changing improvement. So now they're sleeping, their mood is better, they feel different. They will come in just saying they don't feel like themselves, they feel different. They know something's wrong and they're looking for a solution. So they'll see improvement in all of that. And then estrogen, you will only use once you hit menopause. And when you hit menopause, you can get hot flashes or vaginal dryness that progresses. Hot flashes will tend to be a little transient in women. They can be very severe in one woman and then maybe not so severe in another. And so you may not have those any longer if you've already transitioned and you're well into menopause. But vaginal dryness, if you don't have it, once your estrogen drops and you're menopausal and you're not making it anymore, you'll see improvement in that. So prostate massagers, that's that's on our list of podcast topics as well. So again, there's, some mixed data on that. But we're going to cover that in a future podcast. So I think you should definitely keep that one on the alert. And if you're not subscribed to our YouTube channel, there's videos of all of our podcasts, and we have those on all the podcast channels as well. But we're planning that one in the very near future. And so for men, we're going down the list of questions. So how would you know if you need testosterone? So I think, again, most men aren't rushing to the doctor to get a testosterone level unless if they're feeling something else. So it could be that they're not sleeping well. It could just be that they're not it's a life force for men. And so if you're not feeling competitive and driven and you're just feeling blah, not the same, it doesn't always have to be a low sex drive or erection issues, although you will see an improvement in that and you might feel like yourself again. But I think the biggest thing is your mental clarity, just overall outlook, mood, depression, sleep, body composition changes, weight gain. But again, erection changes in sex drive those are probably the biggest drivers for a man too. present and want a testosterone level checked. And so we have so many toxins nowadays that we're exposed to. And so we're just not making hormones like we used to because of that. And so I think that most men don't forget their first testosterone level. We have found that. And you want to look at more than just testosterone. Getting back to the question earlier, one way you would increase that is there's lots of healthy lifestyle changes you can do to increase the testosterone level. And you can limit toxin exposure as well. But just heat, sweating, working out, eating healthily, you can see an increase in your testosterone level with that. Optimal and symptom improvement in whatever symptoms were driving you to have it checked should be the ultimate goal. And you also want to make sure that any provider that's treating you is also looking at, and we do this with women and men, that you're looking at a total testosterone, a free testosterone, you're looking at sex hormone binding globulin. You want to look at all those data points so that you can actually know where you need to optimize. So do we need to take the total test above what we might have thought was a goal just because you have a lot of binding with sex hormone binding globulin so that we have more free and active? So we want to look at all those, make sure anyone is in that conversion to estrogen. So testosterone can convert to estrogen. There's a natural ratio for a man. And some men like their estrogen on the higher side. Some do not like that at all. But typically, you still want estrogen in a man. And so there is still estrogen, just like there's testosterone. The predominant hormone for a man is testosterone, but it does convert to estrogen, which can cause symptoms. And you can get more emotional. You can get water retention. You might get some breast tenderness. Ultimately, you do not want man boobs. So you want them to control your estrogen, and you want your provider to be looking at it. And if they're not, then you need to probably find another provider or push them to do exactly that. Look at the incomplete and entire picture. So when you're talking about HIIT boosting testosterone, like HIIT workouts are always good. So anything like that is going to increase, again, cortisol for a short period of time. But that's a good thing. Those variations are good. HRV is good. And so any of that sweating, working out, period, but those workouts that will increase cortisol temporarily, that are going to increase your heart rate variability will definitely boost your testosterone, whether it's to the point where the level that you want it boosted. Again, I think that healthy lifestyle is going to optimize your testosterone. It may not be to an optimal level for you. It may be that you still have symptoms related to it. And one of the best ways, therefore, to optimize is to really do testosterone in addition to that. And if you're worried about fertility or you're worried about testicular size, you can also always have something that increases or that improves or continues your testosterone production. We use a lot of Clomid. You can do HCG. It's been a little bit less available than before, but you can do Clomid in low doses. If you're over 50, you're probably not likely going to be able to use that alone to increase your testosterone, but you can actually do that in combination with. And so, and I, reason and advice. So, so IVF, again, not an area of specialty for me, but what you want to do is be looking at one of those agents that's going to increase your testosterone and spermatogenesis. And so HCG, Clomid, but those are in higher doses. That's not something we're typically doing. For us, we'll maintain fertility, at least maintain testosterone production, but how they'll follow it. But I think overall, limiting toxic exposures, a cleanup of the GI tract, anything that is affecting toxin overexposure, which is pretty common. I mean, you're talking about phones and electromagnetic energy, and you're talking about toxins that are approved and are in the US all the time, and not in other countries. And so we're exposed to things our livers just can't detox fast enough. So IV fluid is one of those that will help detox significantly, but you can also do a short detox program where you're doing something that actually walks you through like maybe a 10, 14, 21-day detox with probiotics, prebiotics, all of that, just to make sure that you're addressing any kind of toxic exposure, but continued production of testosterone, spermatogenesis, and at a level high enough to maintain or help fertility. So, and then thank you, Eric, for the comment on the Great Live podcast. Thank you. And then, so if you have any comments left, go ahead and drop them. And if you want to have a specific topic that we want to talk about and do a live, I would love that. We can throw comments and questions on the screen and we can address them as it's happening. But I would love to know specific topics you're looking for. What we're looking to do is more of this so that we can connect directly and we can do this. We have a Facebook group for men. And so if it's a male related topic specifically, please jump on and let us know what you want to hear more about. And then also we have one for women, and then we have one just regenerative in general. And so, but we can talk about all that. And I would love to do it in this format where we're addressing it live and addressing questions that are important to you, because there's lots of information out there. We can have 45-minute discussion on just, workouts or just optimizing testosterone for men, look, estrogen for men, which is a huge one, and just how to direct your primary care doctors or whoever is treating you for hormones, how to improve how they look at it and what's right for you. One size fits all is not right for any of them. And I think what we're moving more towards is precision medicine. I will say this, that we get a question every single day about insurance versus non-insurance. We have a cash-based practice that doesn't do insurance, but the reason that I feel so strongly about that is because I want to decide on the care, and everyone that practices at Revitalize, we approach things the same way. So it's not like we're bringing in providers that are used to, and there's a business owner that owns the place, and then they're directing or they're just hiring physicians or mid-levels to staff, and that they're doing different things. Instead,